Well, thank you everybody for joining us here today to talk about how to bill for multiple health service claims done at one visit. I'm also happy to announce that we have a special guest today, Samantha Stewart from Occiden and Company, to talk to us about all the amazing things that she can bring and help your clinic with in regards to efficiency. Okay, so we're going to dig right in here in regards to bills that, when I say combo bills, I mean in regards to when a patient's coming in for a visit, for example, a 03.03A visit, and multiple things are being done at said visit. You could be giving an injection, varicose vein injections. You could be doing an incision and drainage or removal of a sebaceous cyst, as well as a removal of a lesion. And liquid nitrogen as well is another one. Now, when I say combo bills, these bills can be put together. For example, your injection and your 03.03A can be put together and both be paid at full. And the nice thing about all these codes on the screen, they do not require a different diagnostic code for the procedure visit for it to be paid at 100%. And one thing I would recommend if you are doing more than one procedure in a visit, for example, if they're coming in for their regular visit, but you're doing both IM injection and a liquid nitrogen treatment, you can bill for all three in that same health service claim. I would recommend making sure that you put the highest paying procedure at the top after the visit code and then the next lower paying ones below it. The reason for doing that is that way, if there is a reduction, as there may be on some of the lower codes by 25%, then you are losing it off of one of the smaller procedures and not one of the larger procedures. You can also do combo codes when you're using a 03.04A. You can also include a IM injection with that as well as your liquid nitrogen, your your ECGs that are done, as well as your PAP procedure. And again, these are also ones that I would recommend layering. If you are doing multiple procedures, and I have seen different annual physicals that the physician does the complete appointment, does the PAP injection, or does the PAP, also will do an ECG and possibly some liquid nitrogen treatment as well. I would recommend making sure you're putting, again, all those claims on the bill. That way you will get up to 75% of the majority of the claims paid. Okay, and to talk a little bit more about what I mean by the 25% reduction or the 75% payment. If you have more than one procedure listed, your last procedure listed at times will be paid at a 25% reduction. So you'd only receive 75% of the full payment for that procedure if it's in addition to other ones during that visit. Now, that may seem like, oh, wow, I only get 75% of it. But that is why we recommend layering your billing the way that we do. So that way you are receiving that extra percentage on those procedures. Because if you are doing them in the visit, it does help to cover for certain things like your liquid nitrogen costs, your admin costs, and those type of activities. So it's always great to make sure to put all your claims on, even if some of them do play at a lower rate. So that way you're not missing out on those extra revenue streams that could be coming in. Now, this is one that I'd really like to highlight, is if you're doing reproductive health care, IUD removal and insertion. Now, how I have it outlined here on the screen is you can put together a 03.03A plus the 81.8 plus the PAP code for it, as well as the insertion code for it. If you were doing both removal and insertion at the same time within a visit, you can utilize all these codes for that visit. However, the very last one, the 11.71A, will only pay at the 75%. But all in all, these are all the codes that you should be billing if you're doing both an IUD removal and insertion at the same visit. And the nice thing is you do not need to have a different ICD-9 code for any of these. On this claim, you can use the V25 to represent the annual physical for all of them within, for contraceptive management across all these visit codes as well. Now, another one. Are you giving more than one injection at a visit, which can happen, especially if you have a patient coming in, let's say for their B12 injection, and is also grabbing their flu injection and maybe their pneumonia injection at the same time. You can claim for multiple injections. However, you just do submit it under one claim for payment to Alberta Healthcare. Now, in the calls field is where you would enter the number of injections you gave. So if you gave, let's say, a flu injection and a B12 injection, you would put 2 in the call fields. That way you would be paid for both injections and not just one. If you are giving, let's say, 3 injections at one visit, so let's say you're giving the pneumonia, the flu vaccine, and an additional injection that the patient regularly comes in for, you will be required to add some extra text stating why there was beyond 2 injections being performed. You normally would just add that within your health service claim, and they are usually paid. I have not seen too much in regards to rejections when it comes to if you were giving 3 injections in one visit. Okay, and you can use the flu vaccine, the 13.59A for flu or pneumonia vaccinations that are submitted by the nurse. I know not everybody is aware that that code can be used if the patient is coming in just to see the nurse and getting either the flu and or the pneumonia vaccination, but they can. Any other vaccinations have to be given by the physician in order to be billed, with the exception of those two. Okay. And now I'm going to share my screen with Samantha to have her tell us a little bit about her and her company.
Thank you so much. Okay, so can you see me, Dawn?
Yes.
Okay, perfect. So, hello everyone. My name is Samantha. I am the CEO and founder of Occiden and Company. We believe that healthcare and wellness both can bleed money through outdated systems or inefficient workflows, and we work with clinics to fix that. We partner with primary care, specialty care clinics, multi clinic networks, and hospitals just to help recover that lost revenue, protect compliance, and streamline operations. Our clients usually see a 10 to 35% revenue uplift. They save time equal to 1 to 3 full time employees, and they enjoy smoother patient flow and higher satisfaction. How we deliver these competencies at Occiden is through transforming digital systems, and that could be through your EMR, telehealth portals, or a vendor alignment. We work with clinics and healthcare ecosystems to also integrate clinical AI. That can be anything from selecting and embedding AI tools that automate workflows, support clinical decision making, and boost accuracy without adding additional workload. Through that same process, we fix workflows through deep audits to find waste and delays. We protect revenue and compliance, and we can keep everything that we work together to improve to fix with our monthly or full service retainers. A lot of our specialties here at Occiden is truly an EMR audit, digital overhauls, workflow redesigns, AI automation, SOPs, and revenue cycles. But what our love letter is to the healthcare community is, especially in Alberta, through times of great change with our healthcare dividing through acute care, primary care, and so on and so forth. We want to create an opportunity where clinics can take charge of their operations and run a more leaner and cleaner system so that they can pivot their everyday from being reactive to actually being more proactive. And that's really what's been great about working with Dawn is Dawn creates excellent tools that help to really find that hidden revenue when it comes to billing. I believe that in times of great change right now, we have a lot of turnover happening in our clinics. We have a lot of missed trainings. Some people are trained in one way and some people are trained in a different way. So by having the space and creating a space to ask yourself, what if, what would it hurt to look into or inquire or ask some questions? How do you know that you are running at the full capacity of what you can run? And how do you know you can't build a stronger ROI? And that is why we're here today.
That sounds absolutely amazing, Samantha. I do have a couple of questions because
Okay.
I'm sure you face a lot of the same resistance that I face. What
Yeah.
do you find is one of the biggest reasons, or that you've come face to face with, that seems to be why the clinics and the physicians are so resistant to change? Is it fear? Is it just not maybe
Yeah.
like not understanding the tech or?
No, 1,000%. I think that the first step is to acknowledging that there might be a problem. I think that when you get into a flow of running a clinic every day, can be about conquering that day, carpe diem. And it takes a bird's eye view to step away and question if there actually isn't even a problem. So I believe just the initial awareness of accepting that there might be a better way, um, getting over that initial fear opens a door for bigger conversations like these.
And I see that as well too. There's so much I find that you get so stuck in the day to day of looking after the patients that sometimes you don't see the savings or an easier way to do it when it's right in front of you because you're focused so much on looking after the patient that we sometimes don't see the stuff that's right in front of us. So,
Right. And it isn't even just the savings as well, is there's a lot of investment that goes into even owning an EMR and to adding additional doctors and providers to it. And these EMRs are created with a lot of features to help your practice run efficiently and cleanly and have workflows that make the patient experience more seamless. And they're always changing, to give credit as well. So sometimes it's really important to take a step back, and when you're getting feedback from your staff or feedback from your Google reviews or patient complaints, it's hard to really know where to go because you're in it so deeply. But I want to invite the opportunity to be so bold as to take a step back and kind of say, hey, if I don't know if I'm running to the full capacity, then maybe we might need to call in some support. And we have a quiz for that as well, available on our website. It's a free quiz, and you can get an assessment on where you stand with even your EMR usage, your clinic operational usage. And then based on that feedback, you can see where you fall on that scale.
well, that is absolutely wonderful. I wasn't aware of the quiz. I will definitely share that with a few clinic managers that I know who could utilize it.
Yeah.
What would you say would be one of the biggest myths related to AI in healthcare?
Oh, that AI can replace humans. I believe that AI in healthcare is going to be one of the fields where there has to be it's a cohabilitation. And I believe that there needs to be a paradigm shift of embracing it and using it as a tool so that we can deliver better patient outcomes and run leaner systems. AI in healthcare gives clinics an opportunity to elevate their operations like other industries, like hospitality, like aviation, I just released a case study and we were looking at the similarities in managing patient experience. Like, for example, when you order anything from Amazon, you get those notifications, when it'll be delivered down to your doorstep. So, if you get a referral, I think it'd be really nice to just get an update, whether it be in an email and text, and all of that can be automated. And that automation can create an experience for your patients that elevate their perception of you and your clinics.
Not to mention the comfort it could offer them, because I know some of the wait times in our province, especially to get into these specialists, is just outrageous. That I know
Mhm.
myself, even as a patient, I would. I'd feel comfortable, yeah, I might have to wait a year to get in to see that specialist. But if I got that kind of notification or text, let's say every 3 months, letting me know that, you're still on our radar and, your appointment's coming, please hold tight. I
Mm-hmm.
think that would make me feel a little more confident in our system as well.
Yeah, and you have to also consider too is that in a world where demand is so instant and options are available, they might put in a request for an appointment at your facility, at another facility, at a walk-in clinic. They
Mhm.
might book a telehealth appointment. So then you have one patient that has created four appointments across the scope, and they're just going to go to the appointment that responds to them the fastest so that they have more access to. So it's a compound problem in regards to a lot of no-shows that you see. The no-shows come from like, a mutual act almost of not caring. It's creating an environment for an attitude to foster where it's like, well, if they don't care about me, why should I care about this appointment? And they patient might book multiple appointments across the scope and only show up for the one that they have the fastest access to. So that can be mitigated by an AI implement that doesn't take away from your staff time, but adds an extra layer of care in there so that the schedule that you're building stays actually full and you don't have referrals bleeding through.
And that's so true. I've seen that throughout the years in primary care where they will they'll send the same referral out to five different physicians,
Mhm,
because they know it's such a delay to get in. And the primary physicians, it comes from their heart thinking, well, if I send it out to four of them, maybe one of them will get in faster but I don't think
mhm,
they really realize the impact it has on those are four appointments now that have been slotted in those specialist
mhm,
schedule that could be used for somebody else as well. So
mhm,
I find that I've seen a lot of that over the years and unfortunately still see a bit of it, which is
mhm,
I'm hoping that we can get to a place where it'd be nice if we had maybe not a central registry, but if there was a way to be able to know that you're a patient, that if I'm a specialist and Mrs. Smith's coming to see me, if she's been referred to five other people, if we give a patient, we track it with medications.
mhm,
They can't go and get the same prescription from five different pharmacists. That kind of gets flagged. So
mhm.
you would think the infrastructure is, if we can do it with pharmacy meds, we should be able to do it with referrals.
Yeah, and I think like the way to mitigate that is automation in that relationship with that referring physician. Because
Mhm.
at the end of the day, when a physician refers to a specialist, they're trusting that specialist for continuing the care in the needs of their patient. So I believe that there's two relationships that need to be fostered there. There's the update to the patient, and then there's also the update to the physician that refers to that patient. By approaching it from a two-pronged approach, you have an ally that the patient already trusts. They'll get a notification from you of when their appointment is. And then when they go to their physician to ask for more information, their physician is already prepared to say, oh, yeah, absolutely, this is the process of where your referral is, and might even be more weary of providing more referrals to other physicians because they now are on that field. It's like when you get a tracking number from Canada Post, you can look up your tracking number and you feel like, okay, if there is a delay, I know why there's a delay. I see the delay happening. It's stuck in Mississauga. I'm okay. I don't need to call. I don't need to cancel my order. I don't need to use UPS. I have an understanding, and that respect and that peacefulness really helps to manage patient expectations. And without any additional manpower, you're creating an elevated experience through that. And that's kind of where public perception can build, Google reviews can build, um, and your team is spending less time managing the emotional backlash of ignoring it.
Mhm. And I like that how you worded that, a tracking them.
Mhm,
That would be really neat if we could start assigning that type of tracking numbers to different things. It'd be nice to
mhm,
be able to and the data for the province as well, it would give them,
mhm,
accurate, real data on how long some of these specialist referrals are taking.
Yeah. Well, I mean, like, there's Connect Care as well, but I believe that Connect Care is that it's still at a place of opportunity, and even how what you communicated and everything like that between scanning in and sending over the referral update back and forth. But um I believe like that level of experience management can be at a clinical level, and it can be a little bit more of an intimate feeling that's created between the provider and the patient. And then ultimately the results can be uploaded to Connect Care to their file to the EMR. And the EMR can be used as a true profile sheet for patients. I believe that there's a lot of opportunities to really document, does this patient always, maybe they come a little bit late for their appointments, maybe they come a little bit early, maybe they're upset about, what their last experience was like. Maybe they're an escalated patient, and using the EMR to document those trends and those reactions, it prepares the next provider in that interaction with that patient and creates an perception of continuity. So, a lot of problems that might be popping up in the day to day can really be mitigated by managing those expectations, and that can be done through AI.
100%. There's been a
Mhm.
lot of talk lately, there's a lot of patient-facing AIs that we use to help with, different health diagnoses. There's a lot of physician-facing AIs that we use, there's medical scribes, there's different things like that. But I wonder, and maybe you could highlight on what you're seeing in the industry here,
Mhm.
for when it comes to the other care team members. So the administrative care team members, your receptionists, your medical office assistants, your clinic managers. Are you
Mhm.
finding that they feel that the industry itself is providing them with enough of the tools that they need, or are we more heavily focused on what the physicians need?
I think that's a double-edged sword of a question, Don. And I think the current culture, respectfully, is the practice falls on the physician. It is their license that are on the line, and they're the reason that we're all here today. And I believe that the MOAs and our nurse assistants and our other providers, maybe aesthetics, maybe whomever else is involved, and the office managers, they are incremental. I believe that true success comes from recognizing that everyone is important and that everybody plays a role in the bigger picture. And I find that sometimes the resistance to change can come from an emotional cognitive dissonance. Sometimes it's better to be clear, to know what the values of the firm is. Every clinic is different because every clinic is led by a different leadership structure. So I believe that a universal approach is to really foster an environment where every role is incremental and every feedback is worthy of being integrated and listened to. And I think from that pivot, we can create more well-rounded experiences for everybody that's involved on the team.
Yes, I think so too. I know it's been a little slow going for because we have focused a lot on, like AI scribe has been a big one. But
Yeah.
now with these different task sorting AIs and different some of the different stuff that's coming out, it's nice to see that it's just that the AI is expanding to all the team members, which is nice.
Yeah.
Because I do know that, we try to, especially with AI, we want it to be a team member, not to replace a team member. So I'm excited to see where it goes under that focus of, us caring for patients as a team.
You know what? I think what's really interesting is that we're in a time of great creation and great expansion. And even though that's really enlightening, it can cause analysis paralysis. And when there's so many options and you don't really understand the throughput of those options, it's hard to see how they would cater to the different members of the team. So that's why I think it's important to really partner with someone like Occiden, partner with someone like us that can look at the human element of what is the best choices for the team. Because there are a lot of admin elements and admin AI that can alleviate the burden of MOAs, but that doesn't mean that they're not needed. If anything, it creates an opportunity for them to excel within their role and foster even stronger patient experiences and have better work-life balance within their roles as well. So, yeah, I think you're right. I think there's a lot that's out there, but I think that the conversation shouldn't really be what's the latest and greatest. I think it should be what is the latest and greatest that maybe might appeal to us and being able to commit, and stick with it and go from there.
And would you recommend, if somebody is interested in AI, like you're saying, from the human aspect like that, would you
Hmm.
recommend that they kind of, I know because some clinics try to do it all at once, bring in the brand new EMR, all the AI, all this task sorting, everything all at once. So it's a lot of technology for staff to learn all at the same time. Would you
Hmm.
recommend like kind of adding one piece at a time, getting used to it before adding another piece type of thing? Like, is there a stepped approach or something like that that's more recommended if you're bringing in that type of tech?
Yeah, thank you so much. That's a great question. I think the conversation of AI can look like a mountain, but the reality is that every individual healthcare ecosystem will have a different need. So it's important to use it as a tool to meet you where your needs are at. If you're looking to solve a simple problem and one tool can do that for you, then all right, that's what we'll go with. If we're looking to do a bigger overhaul and it's going to require more transformative approaches, what is our end goal and how do we maybe break it up and approach it in a way that works for you, that works for us, that works for the team? So there's never gonna be a one all be all end all approach. It's beautiful in a way that even though there can be a fear there that there's so many options, because there's so many options, you can have the opportunity to create a plan that works for you and that can work with the team that you're on.
Okay. Okay, I have one more question.
Yeah, go
Now,
ahead.
let's say it's a clinic. Would you be able to assist with clinics in this circumstance? Because we know that, family doctors are their own individual business within a clinic.
Mhm,
So some doctors, Dr. X might like to do things one way, where Dr. Y might want to do things a different way. And I know
mhm,
I've seen it myself in some clinics where um, half of the doctors are using a different piece of tech than the other doctors are doing. How
mhm,
would you recommend or do you take on clients as well where they would where it is kind of multiple different systems within the same clinic?
mhm. That's
Like, for
kind of,
example, you could have one doctor using Scribery, one using Talia, one using Makata,
yeah.
where it's not necessarily the same streamline for all of them, but you still have to kind of integrate it in. Have you run into any clinics like that?
Well, yeah, because there's different types of practices that can come into play. They could be managed practices where it's one operational structure and they oversee all the physicians on that site, or it could be more of a contract relationship where that physician is maybe just working within a bigger or a partnership or anything like that. So it's not really complicated. I shouldn't say it's not really complicated, but what the core competency is knowing who the stakeholder is in that engagement. The person that's engaging and looking for this change, they're the ones that might be working with it. So if it's a physician that's working inside of a multi-use clinic, then that's fine. That relationship between Occiden is between us and the and that physician. If there's an opportunity for other physicians that are within that same clinic that maybe have different ecosystems, but they want to create a bridge between each other, that's perfect. That's what we can kind of help to mitigate. So there's no mountain too big because everybody is already going to be different. It's already a given. So whether it's a managed practice or it's whether it's a physician running their own practices, anything. And even what's interesting too is that recently in Alberta, there's been that new nurse practitioner primary care program where NPs now have the ability to have a panel as well. And there's an opportunity even within itself because they can either join a managed practice and have them run their operations, or they can set up an EMR and run their operations themselves. So the conversation is really just going to be um, different with each individual, but that doesn't mean that a customized plan cannot be created for them.
And that's great to hear because there is that misconception in the industry that, and I think that's from our years of quality improvement and that rationale that we had to standardize everything.
Yeah,
There's still that bit of that mindset in the clinic that there's that standardization that has, so if one does it, they all have to do it. But the way technology and everything's going now, that's kind of a thing of the past. The, normal standardization, yes, but each
yes,
individual's workflow, I find, shifts and kind of whips and weaves with the type of person and learner that they are.
yeah.
Yeah.
What I love is that the college outlines all of the rules and standardizations that we need. And um I believe that sometimes we get into a routine of what maybe we see someone else do. So we think that that's the way that we have to do it. But what's really fun about this time, what's really fun about 2025 is that you have choices that are available to you. You have options that are available to you. You have methods of creating a practice or an environment that you work in that's conducive to what your dreams or goals are and to conducive towards the value system of a team. You can create an environment where people are happy to work with you and to work for you without it cutting into your bottom line. So I know that there are rigorous SOPs and processes that are involved, but there's more wiggle room that you think, and physicians especially have um more more ability to maneuver than you think, and more customization is available to you than you think.
Yes, that's very true. Before we close out here today, I guess I would want to ask you is how do the clinic managers and physicians and nurse practitioners, what is the best way for them to get in contact with
Oh yeah. It's everyone too. It could be clinic managers, medical directors, but it could also be tech startups, healthcare startups, AI startups.
you?
If anyone that's open to have a conversation with me, you can reach out to me at occiden.ca, which is our website, and that's spelled OCCIDEN .ca. You can drop a little message in there. You can send us an email from there. You can also subscribe to our newsletter from there. But if you want to reach out to me personally, Samantha Stewart, you can reach out to me on LinkedIn. I'm really active on there. It's one of my favorite social media platforms, and I'd love to hear from you.
And we'll make sure to share all that information in the comment section below where you'll be able to contact Samantha directly.
Thank you.
You're, thank you very much. Okay, and before we go here today, I just wanted to take a minute to talk about Osland Medical Billing Tools tool. Um, This is our Track My Time app, which is available for physicians on the new PCPCM. It helps them with tracking, especially their indirect patient care time that happens after hours on weekends, at times when we usually miss to track that time. It also is completely shareable right within the app to your staff members so they can help load the information into your EMR for you. In addition, you also get monthly EMR audit ready reports to make sure your audit process is top notch in case of being audited down the roads. We also have the CMGP calculator specifically adapted for the fee-for-service position here in Alberta. It helps with tracking or helps with calculating your CMGP modifier units. And previous testing has shown that on average, family physicians are leaving up to $95,000 a year unbilled under their CMGP modifier. If you'd like to learn more, please head over to our website at cmgpcalculator.ca. And I'm also happy to announce, please watch this space because there's more information coming soon this summer. We are releasing Betty. She is the future of billing healthcare intelligence, and you're not going to want to miss her. So please watch this space and keep an eye to see when she will be coming on the scene. We also do monthly newsletters to keep you up to date on any Alberta healthcare billing changes in the province, as well as any updates in the primary care industry. Please feel free to secure or to take a snap of this QR code and sign up for our newsletter today. So thank you, everybody, for joining us here today. I am Dawn from Osland Medical Billing Tools, and have yourself a wonderful afternoon.